Thank you so much for joining us today. I am very excited to kick off this discussion around racism and public health. I am Dr. Angelica Jeter, Chief Strategy Officer of the Black Women's Health Imperative, and I have the opportunity today to share with the rest of our guest speakers how racism has really become and continues to be a public health crisis for everyone, especially here in the United States. So I'm going to see if I can share this slide with everyone. I think we have a few of our other guest speakers joining us. Dr. Benjamin, have you joined us?
Yes, I'm here.
Let's see, I'm not sure. There we go. Welcome, Dr. Benjamin. Hello, Dr. Holden.
Hi, Dr. Jeter. And Dr. Maybank said her link doesn't work. So for our folks in the background, our wonderful tech folks.
It's coming together. It's coming together. All right. So Dr. Benjamin, we're going to have you kick us off, and then we will go to Dr. Verholden, and then I will follow her after that.
So I just like to remind people that race is a social construct without any real genetic basis, and that racism obviously is the view of that one group of individuals is superior to another group of individuals based on that social construct we call race, and that racism unfairly disadvantages the group that's been targeted. It unfairly advantages the group that has feels that they're superior. But I think our whole society is disadvantaged because of that, and that's the real challenge we have here. Is because if you don't engage everyone in our society, that you don't get the benefit of all of our contributions, and that is the challenge that we have when we talk about racism from a public health perspective. Because all of us lose out on a health and well-being perspective when we don't treat people equally. We don't give them the opportunity to reach their full potential. And I think we're going to get a chance to talk a lot more about that from the context of race. And, you know, particularly even if we look at this outbreak of COVID-19, how race has played out in disproportionately causing people to be sicker or die sooner because of historical disparities in health outcomes, as well as ongoing efforts, even in our response, which were unequal in the way we responded to people.
There we are.
Yes, wonderful. I'm literally like, I'm a woman of faith, and I'm like, Lord, please, 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 please. Okay, great. Thank you, Dr. Benjamin, for setting a really great stage for us. Oh, those are not my slides. Those are Dr. Maybank's slides. Okay, I don't know what happened to my slides. Okay, let's see. Let me try. I'll try it myself. Okay, these are my slides. Can you see them?
Yes.
Yeah. Okay, great. So I want to talk about a model that we're working on. And I love how Dr. Benjamin sort of framed the problem for us, and how racism works and how it impacts all of us and gives undue advantage and conversely disadvantage. So the question is then, what do we do about that, right? So we've developed this model called Eradicate Racism, which is bringing together the work of truth, racial healing, and transformation. And you can think of it as akin to the reconciliation work that was done in South Africa together with a public health approach. And, you know, I mean, the president of APHA is on this call. So clearly there's a lot of people here that like we heart public health. So let me explain what I mean by that. So first, just so we're all in the same conversation, characteristics of a disease. All diseases cause deviation in structure or function. Diseases have characteristic signs and symptoms, and diseases cause morbidity and mortality. And guess what? Racism fits all three of those things. So we've all heard about people trying to treat racism in a disease model or people declaring racism as a public health crisis. But literally, we now know the impact of racism, whether it be individual racism, personal racism, structural and institutional. It actually gets under the skin and impacts not only how long people can expect to live, but the quality of the life that they're living. And that happens both in a social context and biologically. It gets under the skin. And we all now know a lot about epidemics. As a trained epidemiologist, I'm really grateful because I had to explain to my family over and over, when they would ask me for prescriptions, I'm not that kind of doctor. I'm the kind of doctor that studies disease outbreaks. And so we now know a lot about epidemics as a society and some basic characteristics. Epidemics are related to spread and transmission of disease. They tend to cluster. And what by definition makes it a definition is it impacts a significant proportion of the population, right? Distinct from endemic, which is sort of the amount of disease that we would normally expect in a population. When we get to epidemic, we see things way in excess of what that endemic state of disease might be. And when you see it globally, right, more than just a community or a state or a country, but affecting multiple nations, we call it a pandemic. And we are in a pandemic. And guess what? Racism also fits all of the qualities of epidemics. It spreads person to person, system to system, institution to institution. It clusters and it impacts a significant proportion of the population, whether you be in a minority or a group or you be in a majority group. All right. And I'm just giving a little bit of background and then I promise I'm going to get to the meat. Okay. Truth, Racial Healing, and Transformation. This is a movement that's been started here. The Kellogg Foundation is the big champion for that. One of the most amazing human beings I've ever met in my entire life, Gail Christopher, really is sort of the brain behind this Truth, Racial Healing, and Transformation work. And what TRHT is it's a comprehensive, national, and very community-based process to plan for and bring about transformational and sustainable change to address not just the historic, but the contemporary effects of racism. And I hear all the time, well, Dr. Deb, a lot of the stuff you're talking about happened so long ago, but it very much has an expression in the modern day landscape. I always tell people as an example, redlining is the gift that keeps on giving. My grandparents being marginalized and the opportunity to own a home impacted their ability to get an equity loan and pay for my college. It impacted their ability to be a stakeholder in making our neighborhoods safe and stable. You look at redline communities, that were redlined 60, 70 years ago, those communities tend to have less greenery, more vacant housing, higher rates of crime. So these historic practices and policies, very racist in origin, very much show up in the modern day landscape. And they are evident in the social, economic, and government policies of our time. I don't know what happened. My PowerPoints just went away and somebody else's popped up. All right, well, I'll trust somebody in the background to bring it back up and I'll just talk without them. I'll let go of my academic crutch and just keep it moving. All right, so great. So TRHT is a basic framework. It has these 5 fundamental pillars of it. The 5 fundamental pillars of TRHT are around narrative change, racial healing, and relationship building, dealing with issues around separation, law, and economy. It also, as a background, racism works at multiple levels. We know that. It's both institutionalized, it's personally mediated, and it's internalized. So what's the Eradicate Racism model? I say, what if we actually treat racism as a disease and use the models that we know in public health work for arresting and slowing the spread and transmission of disease? All right, so let's go for, I can move myself forward. All right. So what's our model? And everybody just think COVID. The first thing we had to do in COVID was identify the problem. We needed barrier-free, community-wide testing for everybody. We needed to identify who was impacted and who was most at risk. We need to do the same thing for racism. That's fundamental to the truth process of TRHT, a real authentic reckoning with our history, our present, and our future, and how racism is literally baked in to everything in our society. So we have to identify the problem, and we've got real skills and tools to be able to do that. We talk a lot about things like implicit bias. And as we think about how you detect cases, not all racism is implicit and not all bias is implicit. We've got good skills and tools in those areas, but we also need to aggressively and head on deal with explicit, overt, institutionalized racism as well. And then we need to interrupt transmission. How do we stop racism, which is baked in? Remember, when this country was founded, people of African heritage were considered 3/5 of a person. If we thought we could just overcome that in a couple hundred years, boy, have we learned that lesson the hard way. So it's about disrupting that transmission and acknowledging that we are all infected and affected by racism. You know, I live in Flint, Michigan, and you will get a lot of upset when you talk about privilege here, because people will tell you, white neighbors will tell me, my white children were poisoned by the Flint water crisis the same way that your Black children were. So this is something that impacts us all, because privilege, not being able to experience that advantage, or the sort of, what's the word I want to say? It's almost like it's like a contagion, and it's almost like a radioactive effect. It impacts communities. So Flint is a majority minority city, but with low political power and pull, our poor white neighbors have been deeply impacted by this as well. We offer to treat the highest risk and most affected individuals, systems, and structures. And that's the work of racial healing and transformation. And then changing societal norms, really getting at how do we then bake equity in. And I always tell the story of my daughter. The first time we baked a cake, we baked one from scratch. And when we were done, I looked on the counter. She's over at the wall oven looking, waiting for the cake to bake. And I see this big box of Domino sugar unopened. And I realized that we had baked the cake and we didn't put sugar in. And she says, well, Mom, can't we just sprinkle some on top? Now, for a 6-year-old, that's a valid sort of question. It is completely not sufficient, given who we are as a nation and what we now know about how to bring about transformational change. We cannot simply sprinkle equity on top. It's a fundamental missing, and we've got to do some dismantling and rebaking of some of the systems and the structures. All right, measuring impact. The big impacts we want to look at are health and wealth. They're inextricably linked. For time, I'm going to move forward because we can talk about it in the Q&A. And so what I'm really pushing for is mandates for equity. I'm jumping all the way down to the bottom. We're trying to build this model up. But here's what I would offer. Our natural drift is to inequity. It's how our society was set up, and things are working exactly as they were designed. If equity matters, it should be a law. And I fundamentally believe that federal mandates and laws would push states to figure it out. State laws would force counties and cities to figure it out. And it would also inspire what we call communities of practice. We know some communities do much better at dealing with issues around equity. Communities that aren't doing as well have very little skin in the game to form that community of practice and find out what they're doing that's working, so that we can begin to model those things and really build a whole bank of best practices around equity. So if equity matters, it should be mandated, it should be enforced, and it should be attached to resources. And because I'm an epidemiologist, I have to say the unacceptable can that we keep kicking down the road is data. In too many places, and we've seen it specifically in this COVID pandemic, I'm in a city where we got a lot of good actors, a lot of goodwill and strong activity around equity. I'm in Genesee County, which is where Flint, Michigan is located. When we were doing our best, we had about 10% missing data on race for COVID cases. In the last 5 weeks, we are now at more than 50% missing data on race. There was actually a law, a federal law put in place requiring all providers of COVID testing to collect race data for anybody that they administered a COVID test on. That law has no enforcement, and laws without enforcement are akin to gums without teeth. In the absence of enforcement, compliance checks, that law sits on the books. It's made no difference. We have no laws like that around the COVID vaccine. So I think we have to start somewhere. And the first thing is we need the data so we can have that authentic reckoning with the truth. And then we need communities of practice and real laws with real teeth behind them to help us develop public health oriented, evidence-based, and promising practice-oriented solutions to solve those problems. Last thing I want to point to, there's a real business case for racial equity and preparedness. Equity actually saves us money. Treating people versus preventing, investing after the fact, solving disaster problems versus making those early stage investments cost us a lot of money. I'm in Flint, Michigan again. The Flint water crisis has cost more than $1 billion of your taxpayer money. For about $1 million, we could have prevented this whole thing from happening on the front end. So there's a real business case to be made for racial equity and preparedness. I'm going to stop there, and that's it. And that's just my contact info.
Okay, so we're going to pray that the slides are going to cooperate with us. And I'm going to try to see, let's see. Okay, those are my slides. Hopefully they will work for me. All right, so again, thank you so much, Dr. Verhoeven. That was a really good, and Dr. Benjamin, great introductions, great overviews of what we know a lot about racism and racism as a public health crisis. Again, I am Dr. Angelica Jeter, Chief Strategy Officer of the Black Women's Health Imperative. I never miss an opportunity to share with the world who we are and what we do. When it comes to the Black Women's Health Imperative, we have been around for nearly 40 years. And we are one of the only national organizations that has a sole focus on supporting, improving, and empowering the health of Black women in the United States and beyond. We were founded by Billie Avery when she made the decision to pull what we call some of her closest, 2,000 of her closest friends, and brought them to Spelman College to talk about protecting Black women's health. And that work that she did almost 40 years ago has turned into what we know now as the Black Women's Health Imperative. And our CEO is Linda Golden Blount, who is amazing. And I have to be clear that BWHI, our very existence as an organization, is an anti-racist movement. We solely focus on protecting the health of Black women, and we are dedicated to dismantling systemic racism to improve the physical, emotional, and financial health of Black women. And it's important for you to understand that, because when we talk about what's happening in Black women in the United States, and I could sit here all day long and talk to you about prevalence outcomes of different health conditions, our life expectancy being 3 years shorter than that of white women. Biologically, when it comes to weathering, it's 7.5 years of us being biologically older, even though melanin keeps us looking quite young. But racism, the stress of racism, discrimination is affecting us on a cellular level. And that is the reality of our experience in this country. We earn less money than any other group at every single level when it comes to our employment. We're more likely to be unemployed or underemployed, and then we were more likely to be the head of a household, which means that although we're earning less money, we are leading our families and taking care of our families in a different way, with less resources than other people. We also know a lot about Black women and maternal health. We have seen very similar charts like this one across the board. We've had those conversations about Black women being 3 to 4 times more likely to die while pregnant and within 1 year of postpartum. And we also know that disparities exist at every single level. Regardless of your educational level, we know that these numbers are still accurate. Some of my counterparts talked a little bit about redlining, and even though redlining is illegal now, we know that there are still the long-term effects of residential segregation, and that ranges from stress, psychological distress, inflammation, pollution, concentrated poverty, and so on and so forth. But what I really wanted to get to within this conversation were a couple of questions that we received prior to when we were preparing for this discussion today. And I kind of went back and forth about how I wanted to address this topic, but these questions are so essential for our discussion because it really highlights some of the very problems that contribute to why systemic racism and other issues that we have as it relates to policy development still exist today. And the very first question or comment that popped up was that many experts are calling racism the next public health crisis. And the reality is that 2020 brought about kind of a new uprising and a movement that has been happening for over 400 years. The reality is that racism has been and has always been a public health crisis. And for Black families living in the United States, it's been a crisis for, again, over 400 years. I was very shocked, and many of my colleagues were very shocked, and not necessarily, yes and no, shocked to hear people say that they didn't know that racism existed, or they didn't know that it was happening in their very own backyard. But the fact that people think that it's a new or the next public health crisis, it means that we still have so much more work to do. So racism is a public health crisis. It has always been a public health crisis. It's been at the center of the work that we have been doing. And although it's taken forever to garner the level of support that we need, I'm happy that it's happening now. Next question that came up is, how do we start breaking down barriers that uphold racial inequality through policy decisions? For me, that lies within 4 key areas: inclusion, funding, resources, and communication. When I say inclusion, we're not talking about people just having a seat at the table and having representation. We're really talking about listening. We're talking about putting money behind the decisions that are being made, and not just short-term funding, but long-term funding and resources that will be available to create sustainable change. We're talking about including corporations, federal, local, and state governments. We're talking about removing certain barriers and closing those gaps to ensure that members of our community have the resources that they need. And the communication has to be ongoing. Without that, and all the other factors that I just mentioned, the change that we want to see will be temporary. We need sustained and lasting change, and we need to ensure that the people that are primarily affected have a seat at the table and their voices are heard, and funding and resources are put behind those decisions that we are implementing. And the last question came up and it said, how is the conversation around racism impacting health policy decisions? One very big example is around the declaration of racism as a public health crisis, and we've seen it at state level, some certain cities. What people don't understand and what they may not hear or talk about is that when you declare racism as a public health crisis, it gives you an opportunity to put funding behind that very issue. It's expanded our ability to support more research and provide access to care in certain cities. I've seen people who have used that as an opportunity to be highly effective in order to expand the conversations around racism and how we can improve and support the lives of those who are primarily affected by racism. Racism, again, has always been a public health crisis. We can't say it enough, and we can talk all day long about the disparities and iniquities. But for me, it's important for us to be clear that it's a crisis, that funding and resources are needed in order to support sustainable, long-lasting change. We need new ways to measure racism. So when we have that data that's available, it can be effective and we can use it in a meaningful way. And we need to ensure that those who are primarily affected have a seat at the table and that we can create something that can be effective for our community. I am going to end it there. I know that we'll have more questions at the end, and I'll share my contact information. And thank you again from the Black Women's Health Imperative. Dr. Maybank, I will pass it to you.
Okay, fantastic. Thank you. Uh-oh. There we go. Okay, great. Good to be with you all. And just an honor to be on this panel with all the doctors. I know 2 of you pretty well and definitely have heard of the others. So just great to be in the space with you. So I'm going to speak about, what does it mean to kind of operationalize racial equity at the institutional level. So I'm actually now in the American Medical Association, representing 270,000 physicians, 100 and excuse me, almost 75-year-old institution. I have spent most of my career in public health, and now kind of in the space of healthcare, and learning kind of the gaps and as well as the opportunities. But my thing to do is, how do we take the context of racism as a public health issue and drill that down to the institutional level so that it actually has impact on the outside and the work that we're trying to do. And so first, I just like to start with honoring the Indigenous people and the folks that have been here for centuries. And they're thriving and surviving to this day. And the acknowledgement, I'm sitting on the land of the Lenape here in New York. And then also honoring and recognizing those individuals who were forced, and communities that were forced from the continent of Africa for the sake of free labor for the production of our capitalist system. And the shoulders that I still stand on today. These are students who are at Tulane, who visited their plantation, not their plantation, a plantation that was close to the med school, Whitney Plantation, recognizing again that they stand on the shoulders and the hard work and the sacrifice of many before them. And I always think about that in the work that I do. I think that's an important part of, as we do anti-racism work, that we always center and acknowledge the voices, the legacy, the sacrifice, and the hope that many have had before us who are doing this work. So again, we can't really do this work well, I feel, and we can't change as a society if we're not looking on the inside and changing ourselves. And so the way that we're embracing this in terms of applying the anti-racism work is an inside-outside strategy. So basically saying that if we do not look through our various structures and our various opportunities that all institutions have, I don't care what kind of institution you are, most of us have workforce, we have our opportunities to engage and have partnerships, we have leadership, we have communications and marketing, data collection, metrics, budgets, contracting, some have advocacy, we have publishing and innovation. If each of these separate units do not figure out how to embed equity, if the teams and the staff do not figure out how to challenge their daily mental models and how they come to this work every day and change some of those mental models, we will continually do the same work in the same way that we have exacerbated inequities over time. And so a lot of the work that we are doing is really also focused internally as well as some work externally. And so the theory of change is, if we do that, then we have an opportunity to evolve culture, and a culture then that is supportive of internal policies that are anti-racist, as well as programs, practices, and their processes around research and evaluation, leading to becoming a multicultural racial justice organization and improving health outcomes over time. I'm not going to go through this deeply, but we've had to go through a process of full engagement internally to do this work. We have met with our teams. We have created accountability infrastructures, which I'll talk about in a second. But important was creating a vision of where we wanted to go internally. This is very different than our external work and the mission of our external work, which is definitely much more explicitly naming anti-racism and equity. Our transform model is from Race Forward, which is the largest racial justice organization in this country, and the Government Alliance for Race and Equity, which is very much connected to it. And we use the model of normalizing conversations around race, power, privilege, creating those shared spaces inside of institutions, and understanding that people need to build a shared analysis around these terms. I mean, I'm sure all of us have experienced the realities that many people don't even know really the definitions of racism, or equity. And if our teams don't know that at the institutional level, if we're expecting institutions to do this work and to be anti-racist, they have to build an analysis. Their employees have to start to understand the language and the terms, the concepts, and how to apply it. Organizing is like creating that internal infrastructure, capitalizing on the champions. It's like really organizing on inside of an institution to make sure that you can get messages out in many different ways and feedback loops that help drive the work within the institution. And then operationalizing is really those tools that are created are brought in that really help challenge, again, the mental models of our teams, so they have them in front of you. And then using data and metrics, absolutely critical, as was already mentioned. The other part that usually gets left out of doing this internal work is the trauma-informed supports that are needed. This work is definitely, we all know is hard, but definitely creates a lot of conflict, has the opportunity to traumatize and re-traumatize people, and we don't want to create further harm. And so it's important to have intentional efforts and opportunities to build systems up that are supporting staff and teams through this conflict. The same thing would happen externally in the work that was described around truth, racial healing, TRHT, truth, racial healing, and transformation as well at the neighborhood or the community level. We have, as a mandate, our CEO mandated that all vice presidents and above had to participate in a 2-day Racial Equity Institute training. But as everyone knows, training is never enough, but it is critical. The people have to build the knowledge and skills somehow or another. And so we have a full curriculum. This is just one aspect of the training, and now this has been rolled out to other parts of the institution. I'm just pointing this out because these are the technical pieces of doing the work. And it's critical to you have to do all of them. This is a confusing slide for anybody who's not in the institution, but my whole point of pulling this up, and to the point that was made earlier about, enforcement, is that it's absolutely right. You have to have an accountability infrastructure to make sure that these things get done, that we do what we say we're going to do. And so we have different levels of kind of work groups and teams across the organization that we're managing to do this work. And this is my 3rd time starting one of these centers, and it works extremely well at the New York City Department of Health. So we're just kind of bringing the work here to the American Medical Association. Also, accountability is, again, collecting the data and having surveys done, and ensuring and mandating that all employees within their tasks and standards, or have equity-specific and explicit requirements that they need to fulfill. And then tool development, which we're getting ready to work on, or actually release some tools around communication and narrative around equity and anti-racism. But this is the critical question of how do we ensure our efforts and innovation do not exacerbate inequities or deny. The critical question for me is the one around the third. It's who benefits from and who will be burdened from our proposal. This is the Racial Equity Toolkit that was created by the Government Alliance on Race and Equity. So you can find it online, and these questions are there, and they also are just really good as you start to think through any policy. We started to train our advocacy team at the AMA on this particular tool so that they can use it. The other part, I mentioned it at the top of the opportunity in terms of as we advance racial equity, we do a lot around, healthcare the space is really big on this language of innovation. And I think innovation can be defined in many different ways. Innovation, in the healthcare context is also often very exclusive, really predominantly for white men, and excludes people of color, physicians of color, innovators and investors of color. And so we're working to do a lot of work to kind of advance anti-racism in that space, but doing that first by centering the voices of all the folks who reach out to us and say they're trying to get opportunities and they can't get opportunities. Another way in which we're at the institutional level advancing anti-racism work is through our engagement, as well as our partnerships and the investments in how we are using our money. We are, for the first time, and I'm not saying that's a necessarily good thing, in our AMA history, it's a good thing on one end, but it's just now, for the first time. Partnering with 6 other healthcare anchor institutions in partnership with Westside United, which is a community-driven effort, which many of you, I'm sure, listening in are engaged in your different neighborhoods. I think what's unique about this is that there are 6 healthcare institutions that have come together to put several millions of dollars and contributing that to upstream opportunities within the west side of Chicago, which are there on the left. And there's a whole kind of really pretty comprehensive evaluation and social impact plan to see if we can actually decrease the life expectancy as related there 50% by 2030. Because this collaborative was in place already, I think of these opportunities as already emergency preparedness efforts. We were able to engage with Westside United and the mayor's office, the health departments engaged to launch racial equity rapid response teams to respond to many aspects of COVID over the last year. Again, explicitly racial equity opportunities. So at the AMA, many folks are very well aware of AMA's history of excluding Black physicians. And the more and more I'm here and the more and more I do this work, just very clear of the roots of AMA and white supremacy and its role in producing scientific racism. And so this past summer, we first, issued this pledge after the public murder of George Floyd. We're now in a time where people are, naming racism and saying the word racism. And I think that's part COVID, probably more so, again, the public murder of George Floyd. And the question is, how do we move beyond the declarative statements of racism as a public health issue to actual action? And so this fall, we also passed and adopted policies, which for AMA, I think for many folks were kind of surprised by this, pretty historic, that we passed these 3 policies, that racism is a public health threat, to rid our healthcare system of racial essentialism. So basically, we recognize that race is a social construct, not a biological one, because in medicine, it really still is used as a biological construct. And then to support the elimination of race as a proxy for ancestry. So that for me has opened the door in the ways that we can do our work now as the Center for Health Equity at the American Medical Association. We've been around for 2 years. And we're getting ready to release our strategic plan at the end of this month. But what's very clear and was already been elevated is that I don't think we can have a commitment to anti-racism work unless we do an honest assessment of our own institution's history. And I've mentioned some of the things of exclusion, the recommendation of shutting down 5 of the 7 Black medical schools. All of those things have had tremendous impacts even to this day on medicine. And so what do we do about that? How do we remedy that? What is the repair for it? What's the restorative justice, the adaptive justice that all needs to happen? We issued an apology in 2008 to Black physicians as a start, but we have much more to do. And then most recently, through more further investigation and action, our CEO, after reading some joint articles that were published from the NMA as well as the AMA a few years back, we're very clear, Nathan Davis, who's considered the father of AMA, the founding editor of JAMA, that he was very explicit about the desire to exclude women and Black physicians. And so the CEO recommended, and it happened, remove his bust from public view at the AMA into the archives, and then we restrict his name from the award as well. Again, small steps, but definitely in the right direction. And so for us, we are thinking through what is that process that we need to go through for truth, reconciliation, and healing for AMA's past. And how do we ensure that we don't do any further harm? Thank you.
Thank you, Dr. Maybank. I believe we have the ability to answer a couple of questions.
Yeah, we've got some good ones in the queue. Can I just take one? It was the first question.
Absolutely.
So somebody asked a question, is the data question primarily collecting the right demographic data, race, gender, et cetera, or are there other aspects of the data problem that are important? And I will offer a couple things. One, if there's goodwill, there is a legislative way. I want to make that really, really clear. I'll point to the example of COVID vaccines. In my state, in Michigan, where again, I said we have lots of good actors. Our governor, our top doc, Dr. Joneigh Khaldun, both very steeped in equity. It is at the forefront of a lot of what they do. The first 2.5 million doses of COVID vaccine that we administered, 44% of those data were missing race of who received the vaccine, and 70% of those data were missing ethnicity. So we had almost no capacity to talk about racial equity and who was actually getting shots in the arm, because we were missing so much data on race, on who was getting it. By contrast, in the initial rollout, remember, we prioritized frontline healthcare workers, people in long-term care facilities, and then next tier, older adults. Those first 2.5 million doses, we had not one missing cell for the age category of the person who received the vaccine. We had not one missing cell out of 2.5 million rows of data. Gender, we had less than 0.1% missing data on 2.5 million administered doses. We had fewer than 1,200 of those people who received the vaccine. Did we not have the gender data for them? The system that we use in Michigan is called MICR. It would take a novice programmer about somewhere between 8 and 13 seconds to add a mandatory reporting field for race and ethnicity. I mean, this is a simple thing. This is a matter of will, and it's a matter of there's no requirement that the data be collected. Because clearly we have demonstrated we have the capacity to collect that data, but we can't just put our heads in the sand and not collect it. And I get this question all the time because people say, well, why don't they collect it? I'm just as shocked as you are. I don't understand. It makes no sense to me. And the CARES Act actually had a requirement in it that for all COVID tests, that these basic demographic variables be collected. But again, laws without enforcement are gums without teeth. I only honored curfew when I was a teenager because the first time I broke curfew, I got punished. My mom didn't let me go out for 3 months. So guess what happened when I got off punishment? I didn't miss curfew. If I had to run in the house and drive my car through the front living room, I would have done it because I didn't want to lose those privileges. I've also heard the statement that people don't want to give that information. That's unacceptable too. This is a healthcare service. When I go to the doctor, they don't ask me for my age and my zip code and my race. They want my exact date of birth, my social security number, my exact home address. I have to provide very personal identifying information to access healthcare services. And if I was unwilling to provide that to my physician, they wouldn't treat me. Why? Because they wouldn't be able to then prove that it was me who showed up for care and get reimbursed from my insurance company. Healthcare consumers in this country are very accustomed to a system of care where you have to provide information if you want the service. And I just ask people to consider, it is very puzzling to me and others why this can keeps getting kicked down the road. It is unnecessary. For COVID tests, we have a law on the book. We just simply have no enforcement of that law. For COVID vaccine administration, we don't even have a law on the book to have a place to begin to address enforcement. So no, there's no other more complicating issue or problem that I know of that would prohibit states from being able to give us that critical foundational piece that we need to ensure equity, which would first be just the data. There's no good reason for it. Okay, since we don't have a moderator, I'll go again.
I know, that's why I'm so are we.
Well, I can say, I can add to that. I can add to that. Yeah, I can add to that. And, you know, the data is absolutely essential. You know, what get measures get done. There's no question about that. Let me just reinforce that. There are some states that do have some barriers in terms of sharing that data, even though they don't necessarily require the capture. You know, they do want you to capture the data. And the truth of the matter is that people may not understand the value of capturing it. And we need to make sure people understand the value of capturing that data. That's the first thing. Now, you're right. In the healthcare setting, I remember when I used to practice emergency medicine, we used to have somebody that went behind us and validate all the boxes were checked. I remember getting awakened after an all-night shift. I went home, I worked a midnight shift, and I went home. And about 10 o'clock in the morning, my phone rings, and they want to know I need to come back in and mark some boxes because they need to bill for their service. And the healthcare side of the house is dead set on filling all the boxes out. Public health doesn't have those systems in place because, you know, the financial part of it has not been a part of the culture, and often is not required. Having said that, that's no reason not to collect the data. You're absolutely right, Deborah. People have to collect that data. Otherwise, we can't make any informed decisions. So for those of us who are collecting the data, shame on us if we don't require it. We need to change that yesterday. And I think that for those people who don't want to give that information, you know, in most cases, any secret, you know, it's not a secret. Now, you may not want to acknowledge some parts of your history, but we need to share that data, and we need to give it, and we need to do it, and understand this information is collected confidentially, and it gets anonymized so that nobody knows who you are. You know, the numbers get bundled together, but if we don't know that people of color are being exposed early in a particular disease process, then more people will get exposed and more people will die. You can't make the adjustments unless you know the data.
And that was
And
so
we can't
important.
evaluate our work either, by the way. We can't evaluate the effectiveness of our work because we don't have data to say whether or not we move the needle. It's required for everything: to identify the problem, to mount strategies that address the problem, and then to evaluate the effectiveness of our work. I'm sorry, Dr. Jeter.
No problem. When I used to lead as chief health officer for a major city in Georgia, and I remember when we had the first cases, and when we realized that the data wasn't available by race. And if you don't have that data, then you can't direct your efforts effectively. I think that people don't think about it from that perspective, with the understanding that data helps us, like you said, evaluate how effective we are in what we do, and then also being clear about where the resources need to go. We can't identify disparities without the data. We know that there are gaps across the board because of the historical context of our experience in this country, but the data helps to drive where dollars can go, where resources can go, and so that we can be intentional with our efforts. I think it's important for us to keep that in mind as well. The conversation that consistently comes up as well in thinking about vaccine equity and how we're going to ensure that people have access to the vaccine if they want it. Being clear about that conversation as well. I would like to see more data about that and seeing how effective that's going to be when it's opened up to everyone. Certain states are doing that to make it easier. But communication, are we ensuring that the people who have access to it now even know that they can access this resource? And is it being brought to them? There are layers and layers to what can be done, and bringing that conversation back to racism and public health and inequities across the board. Vaccines and resources is still a big issue, and we still have a lot more work to do.
I just want to go back. I'll go back to the data real quick. About a month ago, the AMA, the American Nurses Association, and the pharmacists sent a message out to the community of our folks about collecting race and ethnicity data. After having a conversation with the Kaiser Family Foundation, who's been doing remarkable work on, race and ethnicity data, I'm sure all of us have a connection and work and engage with them. I'm totally blanking on her first name. And the lead of data over there was like, the one area, there are all these structural barriers, right? So, there's the issue of mandating, absolutely sure, and absolutely agree. And the issue of accountability, clear. But then there are just tremendous structural issues as well related to that, as Dr. Benjamin mentioned. But there's this gap that we were hearing the stories, and healthcare does not get off the hook for this. Maybe in some systems, there's some accountability, but we were hearing stories. And when you're in a moment of crisis and there are all these sites that are all over the place, and I've gone to some of the mass sites myself, not the one, in New York City, the Department of Health, that went out there or anything, but, visit with my mom when I was in New Jersey, they didn't ask about race and ethnicity. We just, went through the line. And also just hearing stories of folks, just filling out for folks, which is not the right way to collect race and ethnicity. Right. And so what we were hearing is that, physicians were uncomfortable, and healthcare providers, not even just physicians, because it's other folks doing that level of intake, were uncomfortable with having these conversations. And so what we did in that letter was just, again, express, about the importance of it. Why is it important in terms of what was just elevated as far as the equity strategy and being able to guide resources, but also to provide them with tools on how to have a conversation around race. It's all of these things become absolutely critical in order to move this forward. But I agree that ultimately policy enforcement mandates always, are the structural solutions that need to happen.
But can I offer something? Because I think that's a great point and a great conversation, which is when I went to get vaccinated, I had to fill out a little card. If somebody truly checks the don't know or refuse, that's their right. But the Criminal Act is not even to ask. Yeah. And so we can talk about training people to ask. Everybody has to fit, and everybody, I'm seeing it on social media. Everybody has their card and they're so happy. You're not just pulling up and getting a shot in your arm. Everybody is having to do something. If we care about it, people can self-identify. They can check don't know or refuse. But to not even ask and to kick that can down the road, all I want is partners in outrage. I want a whole lot of people to be up in arms with me. If we said in that initial rollout, 70% of the data was missing age, so we couldn't ensure that we were actually prioritizing older adults, every geriatric-oriented group would be up in arms. But we somehow seem okay, and that's the internalized impact to me of racism. That somehow when we find out there's 44% data missing on race and 70% on ethnicity, we tilt our heads and go, why is that? But we're not up in arms. I think we need to be up in arms about this because it is so preventable and avoidable.
I think there are people who are up in arms. I know the advocacy of many groups, who have been advocating to the federal government level about this. I think enough people are not up in arms. Like, who is up in arms? That's the question, right? Who's really fully advocating for this and for this change and for this opportunity? As you said, a lot of this is about will, honestly. If people want to do it, they will absolutely do it. But I don't want to, keep on the race or the data conversation if folks want to move on to something else.
We know one thing. No physician in this country and no nurse in this country graduated from medical school or nursing school and were allowed to not put race, ethnicity, take a social history, do allergies. All the boxes had to get filled out, or you did not graduate. So we know they know how to do it. Something has happened between the day they graduated and the day they went out there on the line to get.
It's called racism. Yeah. That's what's happening. That's what's happening.
This is a great point because they had to do it. It was attached to something that mattered to them, called getting that degree.
Absolutely.
People get the vaccine without filling out the data. They have no skin in the game.
But now they don't have that accountability. Absolutely. So now that accountability is not there. And so you revert back to what is the norm and what's comfortable. And so if you have not fully valued people in that way, then why are people going to do it new? Right? It's not part of the system, the internal system of people to do and providers to do if they have not been doing it for the right reasons, right? And they understood the impact of doing that kind of work.
Well,
go ahead, Dr. Benjamin.
Well, I think we ought to just move forward to the other issue of the fact that we knew that we were going to have structural problems, even on the response to COVID.
Yeah.
Why didn't we put testing sites in the hood? Why didn't we go right away, even within those categories, and focus on the disparities when we're giving vaccinations? We knew that was going to happen. In the state of Maryland, their solution to addressing disparities was to put more people in queue instead of focusing on the people within the category they already had. And that was crazy, right? And the answer is, I have no idea why people are thinking that they can solve disparities and inequities in a casual manner. And we know how to do it. The problem is, we know that getting the data, focusing on the population you want to focus on, measuring it, holding yourself accountable, adjusting when you need to is the way to deal with health inequities. You know,
And
so
attaching it to resources.
Yeah,
Attaching it to what you
always
imagine.
attach it.
Yes.
I would love, this is why I'm proposing to bring TRHT and Dr. Maybank. I just love the work that AMA is doing. And when you took that position, I was like, you would have thought it was like me in the role. Like I just want to be clear. We got a real warrior and a champion for equity now in AMA. So I just salute you, Dr. Maybank, because I can only imagine you're working really hard and pushing a boulder uphill in an institution that is also probably got a very weak muscle around equity. So thank you for all of your work. I know it will be transformative in medicine and healthcare.
I appreciate that. And I think it's important to have those opportunities to amplify, because for those, I know Dr. Verholden for a very long time.
We went to college together. Just say it. We were in the same little freshman cohort at Johns Hopkins.
We sure were.
1992. That's right.
So, but I look forward, and same with APHA, and Dr. Benjamin's the work that you have been doing. But I'm all for bringing TRHT kind of, to the profile, like out there. We're about to release the strategic plan, and it is in there for us to do. So I think we need to amplify that.
TRHT has a transformative potential to change hearts and minds. When we marry that with public health and we change systems and structures and policies, that's where I think the two combined become greater than the sum of their individual parts. Because we'd love to change hearts and minds. But I always say, in the meantime, I'll settle for policies, systems, structures, and institutions.
Hi there. This is Emily from State of Reform. I'm sorry to have to cut in, but this panel is going to end right on the hour, so I didn't want it to cut you all off. But this has been amazing, so thank you so much.
We should have
Thank you.
panels like this.
There was one last question, though. There was one last question about what is AMA doing to support and recruit. So maybe Dr. Maybank can close us out with that.
So, and thanks for your comments about AMA. The reality is, we had our JAMA podcast, of which it said, racism doesn't exist, and that causes, us the ball fell down the hill, and now we got to kind of push it back up the hill, right? But it speaks also to all the work that we need to do as it relates to the diversity of medicine understanding. We issued the Flexner report that created the lack of diversity. And so what we've been doing it differently, and not just stepping into the space and saying this is what we're going to do, is reaching out and engaging with all the folks who have been doing this work over the last 10, 20 years, so that we have a better sense of where we need to step in as the AMA that is additive to the existing work that's happening. So for the last year, we have been having, we've had multiple kind of interviews with many folks that I'm sure you all know, so that we can start thinking through what our strategy is going to be for this year. We have a lot of connections to the PowerPoints, not the PowerPoints as in slide decks, but like the points of power that I feel that's where we should be acting as the AMA.
Yeah, I'll be definitely reaching out to you, Dr. Maybank, as it relates to BWHI's anti-racism initiative that we're establishing. So we would love to have you be a part of that conversation. Thank you for your work. And I think an invitation is being sent to you as well, Dr. Benjamin. Now that I have your info, Dr. Verholden, we have to connect as well. I love it. This has been great. Thank you all. It's great to formally connect with all of you.
Absolutely. That was fun.
It was fun.
The free flow.
Have they cut us off yet?
That was fun.
Oh, she ended the webinar. She ended it. Thank you all. This was
5, 4, 3, 2, 1.
I know.